Normally you don't see this in runners, but I've been seeing a lot more in the last 2 years. And the typical profile of this would be a runner would be usually a middle-aged male who is doing a lot of ultra distance or trail running, a bit of change of direction, and they're getting slightly older and they're losing that flexibility of the hip. So generally,
Right. Okay.
they're losing that hip extension. So as you get, one of the interesting thing is as you get older, especially in men, you lose that hip extension. That's part of your normal aging process. And when you lose mobility, there's more strain on that region. So generally, somebody in the clinic, I would see a runner. I'm talking about runner. If I'm seeing like a younger population, it's generally football, rugby, and basketball, something like that. If I'm seeing that in a runner, it's generally like a 50 plus runner who's doing like long distance ultra marathon or trail running. And like men, we're quite bad at this. They come very late. They put on it. They put on it. They don't seek help early. Like, I'm also one of those where we think it's going to get better.
We
You
can
just
handle
delay.
it. I
Yeah,
can
we can
fix
handle it.
this.
Yeah, fix this. So that's the second group you see, is that middle-aged men who doing like trail running and things like that. There's a third group also you see is postpartum. So they're given birth, they've been running before, and they get into running. So postpartum osteitis pubis is also a well-recognized condition where after delivery, and that can be quite. And usually, I get a lot of referral from other, women's health physio where they get a bit of hip and osteitis pubis. They have done all the inner work like pelvic floor and things like that, but the pain is not improving. Then they come to me because it's merely a pubic related pain. And then the final.
So thank you for joining us, Ben. So if you wouldn't mind just telling us a little bit about yourself and your professional work.
Thanks, Matthew, for the kind invite. So I'm a physiotherapist based in London, been physio for more than 22 years. For the last 12 years, I've been predominantly working with hip and groin running population. So I work both for the NHS, which is the National Health Service based in UK, and also work in private practice in central London, a clinic called Life Plus. So pretty much okay, and I'm involved a bit of teaching as well. I've been teaching for the last 8 years, pretty much working on running and hip population. And I'm currently writing a few book chapters on that as well, focusing on with other physios. So my day, the patient group I really enjoy is runners, and especially with hip and groin is my sort of area. And I usually get a lot of second opinion, third opinion runners who've sort of seen other therapists. They're sort of stuck, and to come up with a plan and things like that. So that's what I would say. And I'm also involved in shockwave education and other bits and pieces. So, but predominantly, it's mainly lower limb runners and things like that.
Yeah, and it's interesting you mentioned the second and third opinion kind of thing, because I know as a clinician, treating groin pain is just, as soon as you see it on the list for your day, you're like, oh man, this is going to be hard. It's such a difficult thing to resolve.
Yeah.
So, why is that?
Yeah. I think there's, I would say there's 2-3 reasons for that. One is the pure amount of muscles which go around the hip and groin. So, if you, do a little bit of anatomy work, you can see there are at least 26 muscles which cross in the hip and groin region. That's a lot of muscle in a very small area. And you got these powerful muscles like your adductors, your thigh muscles, your lower abdomen muscles, your hip flexors, all coming into a small area, a lot of forces going in. So, in fact, there's more muscle than the shoulder. So you could argue it's more complex area where you can't really pinpoint. And the second, I would say, the important factor is if somebody comes with a knee pain or an ankle pain, you can just feel the joint. Whereas the hip is so deep, you can't just put your hands and think it's on the hip joint itself. So, some practitioners might think you can palpate particular muscle like the psoas or anything. I would say anatomically, it's quite impossible to really put your hand and say like I'm on this muscle or I'm on the hip joint. So you can't really feel it with your hands. As therapists, suppose you come with a wrist pain or elbow pain, I can feel it. Whereas a hip, you can't really feel it. So a lot goes from the history and the pattern recognition. So I think because there's so many things going on in that region. And another factor also is, like you can get problem from the stomach, ovaries, gynecological problems also going into that region. So it might not be even nothing to related with your muscles. It could be something else as well. So I guess those are the reason. It's deep, 26 muscles, a lot of referral pattern from the back, SIJ, and the organs as well. So it's quite a complex. It's fair to say, and in fact, in sports medicine, we call it the Bermuda Triangle of sports medicine. So
okay.
it's sort of you get lost, you'll never come back. so that's the reason. So right from the onset is and also you need to, like any area, you only get good at it by treating a lot of those patients. So most therapists might not see enough of hip and groin.
Yeah,
So
definitely.
an average sort of week, I see 10 to 15 every week, whereas most therapists might only see 1 or 2 in a month or so. So you need to see, I guess the only way to get good at anything is to see more of it. It's an area, because it's so complex, many people don't treat enough. And because of that, you never get good at it, because you're not seeing enough numbers. So it becomes like a difficult area to get in and be specialized in that.
Yeah, I would definitely agree with that. Like working as a physio, I mean, even still, I'm like, I don't know, 15 years in or something. And all the people I'm seeing at the minute for groin or mostly groin stuff, I'm like, I'm not sure I'm exactly convinced of my, clinical impression. Whereas most other like regions, like you said, if this is the knee or the ankle, I'm like, yeah, I know what's going on here. Whereas the groin, it's sometimes like, I think it might be this. So this is what we're going to do. We'll see how it goes. And I'm never quite sure what investigation to order and when and who to send them to. It's like you said, it's a bit like a Bermuda Triangle. It's very difficult. And I think that's why people end up, going elsewhere, because, as clinicians, especially when we're not specializing in the area like you do, we're struggling with it. And then those people are getting frustrated after, 6 or 8 weeks, and they're moving on, trying someone else who's getting equally frustrated. And then you get this sort of, I don't know, like a merry-go-round. You just keep moving from one to the next, and you're not getting anywhere. It's very, very hard region to address
Definitely.
the issue fully.
Yeah, I would say it's because I'm not saying just because I'm in that field. I would definitely say it's a specialist area, because you need to have that bit of expertise and also volume. I don't think it's just a knowledge thing. Is you need to see a lot of those patients to identify the patterns and the variation. So it's like, for example, if you look at a shoulder, if you have instability, which is a bit more complex, rather than a normal cuff or Achilles, if it's simple like tendon or like a posterior impingement. So there are a few specialist area where I think as therapist, getting a second opinion, and I think it's great to see more and more therapists. We can never be good at everything. If I get a complex back, I will send it to my different colleague who deals with that sort of area. So there's no harm in working together, because we can't we can't really be good at everything. So it's like, and patients also understand that, like therapists have different specialize. Like you might be good at knees, you might be good at foot and ankle, you might be good with dancers, somebody else might be good with runners. So it's like seeking that sort of niche areas, which I guess will become more and more common. Like in orthopedics now, we get surgeons. Like I work with hip surgeons who just only operate hip; they don't even operate anything else, and shoulders. So it's becoming more common in orthopedics. So I guess in therapy, I guess that might be a trend we might see, where we might get a physio who just treats spine, somebody who just treats upper limb and lower limbs, which I guess it's great for the patient, because they're going to get that specialist care.
Yeah, and I think that'll get easier especially with now people are getting more used to online consults. You could have like a joint consult and things like that. And it's like immediately I got this question about a runner with groin pain, and you just popped into my head immediately, because you've done so much work over the years, educating the sort of physio community on how to treat hip and groin issues and how to diagnose them. So it's like, okay, at least I know someone I can ask about this, whereas previously would be like, I don't know, you Google it, you get some kind of very, very, I don't know what the word is, but superficial kind of explanation. And it usually says you have to do physio. And it's like, yeah, well, what kind, for how long, and how do it die? So if we jump in there, we've got a runner and they're having pain in the groin region. What are some things that might be causing that pain?
Yeah, I think we can approach it in different ways with that, because most of the things is by the history. So a key factor would be in fact, the most common reason I see clinically for groin pain is coming from the hip joint. So referral from the hip joint itself, and age is quite a good criteria. So if you look at most guidelines, if somebody comes with groin pain after the age of 45, in fact, it could be a sign of early osteoarthritis of the hip, which is not uncommon. So most people get it after 65, 70, but some people can get in their late 40s or 50s. So for me, I think the key differentiation would be is obviously we take a look at the general health. If they're getting back pain or pins and needles, we need to rule those out. Is it coming from the back and things like that? But to make it quite simplified, we can put into two categories. Is it coming from the hip? Is it coming from the groin itself, what I call the local problems?
Mhm.
So I'll just briefly mention about hip, but I think we'll prominently focus on the groin. So
Okay.
hip, I think, is general rule is if it's 45, 50 plus, it might be a sign of osteoarthritis. So a few other things which might give you it more likely to osteoarthritis is a family history of early replacement. If your mother or dad had an early replacement, if you're getting a big key question I ask patients would be is, do you have stiffness when you put shoes and socks in the morning? That's a sort of major giveaway. If you're struggling, so I had this patient last week. The first, he had he was actually a runner, 55-year-old. And he said he had to ask his partner to put his socks for him. That immediately tell me that it was osteoarthritis. It's quite a very important question. Is stiffness in the morning, getting that from that. For a slightly younger population in your 20s and 30s, there's a condition called hip impingement or femoral acetabular impingement, which is quite a detail. We can go at a later stage. So those are the more likely to. So if it's coming from the hip joint, they'll usually have difficulty in sitting. They might have like clicking, catching. They might struggle with change of direction, things like that. But those are the hip things. So if you look at the groin, that's where I think the main focus we might be exploring today is there are about 3-4 common things which I see in runners. So generally, most runners don't come with hip and groin. Most they come with knee pain. So hip and groin, that needs a bit more. We might have to go in more depth on that. So if you look at groin, we generally there are 2-3 conditions which I see. One is quite difficult, devastating injury called osteitis pubis. Is one of those conditions where if somebody comes in, I know I'm going to see this patient for 6 months to a year. It's a very long. We can go into that detail. There's another condition called, adductor, the tendons of the adductors muscles. Scientifically we call it adductor-related pain. So that's the second reason. There's also a very rare condition called sports hernia, which we can go through that. So generally, if you're talking about when you're talking about true groin problems in a running population, it has to be osteitis pubis, the bone-related problem. It could be the tendon, which is the adductor muscles, and it could be another condition called sports hernia, which and the funny thing is they're all in that small area. So that's why right from the beginning, I would say if you're struggling with this sort of injury, maybe it's a good idea to see a specialist to sort of untangle that and find which of the three is the problem. So as if I see somebody with the groin pain, the way I think about it, the logical progression I would go with stage one is to make sure it's not coming from the back or something like sinister, like from the abdomen, general health, blah, blah, like that. Stage two is making sure it's not coming from the hip. And stage three, if it's not the hip, then it's usually one of those three, osteitis pubis. So this is my thinking, my logical process of going through that. So if it's groin pain and runners, it's usually one of those three.
Okay. So the first thing we want to do is try and make sure that we know it's coming locally from the groin, as you say. And before we get to that, we have to decide, is this a pain that's being referred from elsewhere, like the back, the hip, or the let's say
abdomen
the organs,
or something like that, like lower abdomen. It could be sign of other things, if they have, suppose they get groin pain and they're also getting frequent diarrhea, they're getting bloating sensation in the tummy, they're going for frequent urination. So it's important to ask that. A lot of stomach and pelvic pathologies, like if it's a female runner with groin pain and she's saying like she gets pain during sex and the pain in groin changes during every month, it goes during the menstruation cycle, it changes, then it could be a gynecological problem. So we always have to be mindful that groin can be caused by non-musculoskeletal. It could be caused by not just muscle, tendons, and bones. So urinary function, stomach function, general health. So I'll definitely screen for all those things to make sure. If those questions are positive, then I'll refer back to the general practitioner to check their other function, because it's not my area of expertise. So we need to be mindful that as therapists, it's easy for us to jump and blame everything on muscles and tendons, but sometimes it's not the cause.
Yeah, we almost assume just because they're here to see us, it must be a muscle or a tendon or a bone, and it's not always. And
Yeah.
so, I mean, the way I phrase that, and you can tell me what you think, is non-mechanical patterns to the pain. So it's like you said, it's to do with your menstrual cycle or your digestive issues or pain during the night when you're not really doing anything. Or, so
there's not a mechanical pattern to it, so that makes you think like maybe it's a referred pain from some systemic or some organal, like pelvic floor or something like that. So it's always good to be mindful of that. So that's my main focus on the first session, is to make sure, is it something where I should escalate to a medical professional rather than just starting them on physiotherapy.
And then, presuming it's not that, and then you're moving on, okay, I want to rule out a hip-referred pain. So you're thinking, in a older, I think you said older than 55.
45 generally is quite scary. So I'm slowly hitting that. And, 45 plus. And one of the biggest factor for that is genetic composition. It's sometimes early arthritis in the hip runs in certain families. And if you've done a lot of rotational sports when you're young, like football, that can sometimes lead to early, changes. And so sometimes it's a family history, previous injuries, those sort of things. And it comes very slowly. You don't get symptoms very quickly. So generally, the main thing is a feeling of stiffness. Like usually if they're sitting for a while, and especially with prolonged sitting, they might, if they go for a lot of running, they might limp the next day. And it's quite deep-seated. You can't really... so a key difference between hip and groin problems are, with a true hip problem, you can't really pinpoint where the pain is. It'll be very vague. So they'll say it's like, they usually use a sign called a C sign, where they sort of keep the hands around the groin and it's somewhere deep. So if a patient can't really localize the pain and it's quite vague and deep, it's because, as I mentioned before, the hip is so deep, nearly all patients with hip pain can't really pinpoint it. So then you might be thinking, if it's more deeper, then it's the logical conclusion is it's more likely coming from the hip joint itself. And then you might decide to do an X-ray or an MR or something like that to see the joint itself. So important thing to remember is groin pain can be sometimes the first manifestation of a hip joint problem. So that could be a first sign.
And then you're looking for some of those other things you just mentioned: stiffness in the morning, stiffness on getting up, limping, pain.
And also when you're going to the gym, suppose you are in the gym, you might have difficulty squatting, prolonged sitting, that sort of cycling, rowing, anything with the deep flexion, the hip can get lightly irritated. So it has that mechanical property as well, where when you're suppose you're squatting in the gym and having heavy weights, when you go in the deep on that, you feel that sort of pinching feeling, and that generally means the hip is not happy with that. And a lot of people believe, oh, I've just got a tight hip flexors, I need to stretch it, but it doesn't get better because it's not really a problem with the muscle. It's the hip joint doesn't like that. Nothing wrong with the squat itself, but that range, the body doesn't like that depth. So it's telling you that it's a bit of a block. So pain in sitting, that bit of stiffness, that bit of difficulty in prolonged flexion base, like squatting, cycling, that should really, you might also have a bit of like a clicking, catching feeling like within the hip. So when somebody says this sort of symptoms, I will have a high suspicion that it could be coming from the hip joint itself. And it's very subtle. It doesn't happen overnight. It could be a gradual progression over a few months. And the key take home there would be none of the patient will be able to tell you. So I use something called the finger point test. So I'll ask them, use one finger. Can you pinpoint where the pain is? If it's coming truly from the hip, you will not be able to say with your finger, because they'll say it's here, and it can change. So if a patient can't really put a finger on the pain, then you can assume that it's actually quite a deep problem.
Okay. So then we're happy it's not for the hippie then. And now we're moving on. We say we got three main causes or suspects when we come to groin pain in runners. And I think we'll start with probably, I think what you were getting at is the least likely would be abdominal muscle problems. So could you tell us, could you tell us a bit what that is? Because that can be a confusing term for people because they think, what's the difference between like a sports hernia and a regular
Yeah,
hernia?
yeah, that's a great question. So I think it makes sense to start with what's a normal hernia. So most people understand what's a hernia is basically a protrusion of content which should not be there. So there are two basically hernia, a true hernia which you see in the groin region. What we call the groin hernias is femoral hernia and the inguinal hernia. So you generally get a bulge pain and the bulge. A patient when they cough, they'll feel a bit of a bulge, and usually it's a content from the ball or from the omentum, and it's sort of they'll have that heaviness. And GPs, general practitioners, are very good at picking this up. So they'll send them for an ultrasound scan. The scan will show what type of hernia there are. Basically, if you want to be really go in detail, so there's something called direct inguinal hernia, indirect inguinal hernia, a femoral hernia. As a therapist, you're very less likely to see this because most GPs will pick this up very quickly because they've been trained in that sort of area. They'll send them for an ultrasound, and then they'll say he's got a femoral hernia, he's got an inguinal hernia. Inguinal hernia is generally managed conservatively, which means they don't need to rush for surgery. In a femoral hernia, they might rush them for a surgeon. So that generally it's a medical. I wouldn't say it's something which many therapists will not see because these are picked up by the medical professionals. So first, let's assume that the true hernia has been ruled out. Then you get a subset of something called sports hernia. So the name itself is a bit of a misleading term because there's no hernia. There's nothing bulging out. There's nothing popping. So it's, people are looking for hernia. So generally, this is very frustrating for patients. Now, the good news is you really don't see this in runners. So this is something which I would say in the last 15 years, I've not seen a true sports hernia in runners. The only person I see with sports hernia is high-level elite male who do football, rugby, rotational sports. So it seems to be an exclusive problem. You do can see it in other areas, but generally, if a runner comes to me, that would be last on my radar. Because it's pretty much for all practical reasons, it's extremely unlikely to see it. So when I mean by sports hernia, basically it's a better term for a sports hernia would be core muscle injury. So basically it's a defect in the posterior abdominal wall. It could be the rectus oblique. It could be upper neurosis. Basically it's the lining, and you could have small tears, and that again it's a specialist area. So even in the hip, there are only few people I will send that for that sports hernia. So the pretty much the type of people I'm seeing is young 25 below males who are doing football, rugby, like that. And that when you palpate, you can't feel a bulge. But when they're doing any in the gym, they're doing like sit-ups, then it reproduces pain. And if you are sort of doing zigzag motion, like cutting in different direction, you feel the pain. So and if you look at professional sports, like if you follow football, like John Mathew from Man City, Man United, Jamie Vardy, all these guys. In every season, there'll be one or two who will have this problem. They go and get operated. So outside elite football, rugby, basketball, you're unlikely to see that.
And it's unlikely to hurt when they're running just because there's not enough twisting and explosive movements to put the stress on that abdominal area in such a way that it's going to injure or irritate those muscles. Okay, so then we're thinking it's probably not that if we've got a runner, and we left with two more suspects. So what are they, and how would they present?
Yeah, so Osteitis Pubis, basically it's a non-infective. So basically the patient will, so basically it's like pain around the symphysis pubis, basically the bone in the middle. This is unlike the hip, the patient will exactly tell you where the pain is. They'll just put the hands in the middle of the groin, on the finger. They can pinpoint, and sort of the pain can go a little bit towards the abdomen. It can radiate, but again, they'll tell you where is the area of maximum pain. You can't miss it. It's bang in the middle.
Sort of like a epicenter. Like that's where the pain is, and it kind of comes. Okay.
It can go up, it can go down, it can go to the side, but generally they say right in the middle of my groin. It's my symphysis. Like if you're a therapist, it's pretty much on the symphysis pubis. So you see that. So it's it's one of those things you can't really miss that because the patient will really guide you exactly where the pain is. So osteitis pubis, it's sort of a poorly understood condition. So it was actually first described in 1924 by a urologist, by not even by an orthopedic surgeon. So if I looked into sort of in the clinic, there are about generally 3-4 types of people who get this condition. So again, number one, I would see is that professional rotation sports, football, rugby, blah, the same people who get that hernia. So you get that. And normally you don't see this in runners, but I've been seeing a lot more in the last 2 years. And the typical profile of this would be a runner would be usually a middle-aged male who is doing a lot of ultra distance or trail running, a bit of change of direction, and they're getting slightly older and they're losing that flexibility of the hip. So generally,
Right. Okay.
they're losing that hip extension. So as you get, one of the interesting thing is as you get older, especially in men, you lose that hip extension. That's part of your normal aging process. And when you lose mobility, there's more strain on that region. So generally, somebody in the clinic, I would see a runner. I'm talking about runner. If I'm seeing like a younger population, it's generally football, rugby, and basketball, something like that. If I'm seeing that in a runner, it's generally like a 50 plus runner who's doing like long distance ultra marathon or trail running. And like men, we're quite bad at this. They come very late. They put on it. They put on it. They don't seek help early. Like, I'm also one of those where we think it's going to get better.
We
You
can
just
handle
delay.
it. I
Yeah,
can
we can
fix
handle
this.
it. Yeah, fix this. So that's the second group you see, is that middle-aged men who doing like trail running and things like that. There's a third group also you see is postpartum. So they're given birth, they've been running before, and they get into running. So postpartum osteitis pubis is also a well-recognized condition where after delivery, and that can be quite. And usually, I get a lot of referral from other, women's health physio where they get a bit of hip and osteitis pubis. They have done all the inner work like pelvic floor and things like that, but the pain is not improving. Then they come to me because it's merely a pubic related pain. And then the final group, which I never see them because they generally don't come to me, is that patients who develop osteitis pubis following urological surgeries. So they go for like some sort of kidney issues or urological surgeries, and it is well known that that's a complication after 6 to 8 weeks. So usually it's seen by general surgeons. So what I see generally is that top three is middle-aged runner, the young footballer, or women after giving postpartum osteitis pubis, which can be very difficult to treat because a lot of time they are kind of treated by women's health physio as pelvic girdle pain, but then it doesn't improve at all. So those are the mix. So it's quite a sort of varied presentation, but generally the pain is other pubic bone can spread to your lower abdomen. It can spread to your adductor muscles, and extremely, and it's one of those conditions where once it gets worse, you can't ignore it. You have to. By the time they come and see me, nearly all of them have stopped running for 2 months, 3 months. So it's
Right.
something which you can't shrug off easily. So, and then they have difficulty in sitting. They have difficulty in cycling and rowing, anything with prolonged sitting. And sometimes even they come to me in limping. They're such in severe pain, and they have pain during sex because anything which puts strain on that area. So it's one of those where can be very devastating for a runner because it's not like a simple ITB injury or something like that where you can
can't
just
run through it. Yeah.
you
It
can't
will
run through
sort
it.
of stop you. Yeah.
Yeah,
Could
it'll
you,
stop
could you
on
just
that.
explain just for the listeners, what the term osteitis pubis, what does it mean? What is actually hurting and why is it hurting?
Yeah. So official definition is, let me use something which might relate to a runner. You could sort of compare it to medial tibial stress syndrome, like shin splints. So basically, it's initially it starts an inflammation around the bone itself. So it's a part bones, part soft tissue. That's why it's more difficult. So when we do an MRI scan, we can see inflammation within the bone itself. We can see swelling within the bone. So it's not like because you got tight hip flexors or tight hip adductors as well. So the bone, it gets overloaded. So basically, the stresses on that region has been too high. And we have to remember, bone is a living tissue. It also adapts like a tendon, like a muscle. When the load is excess, it just, the body is always breaking and building all the same time. You got osteoblast and osteoclast. One is breaking, one is building. When the balance is not right, it just goes a little bit havoc, and then there's a bit of swelling. And we know the periosteal, the inner covering of the bone, is very sensitive with nerves. So, and it's very painful, extremely painful condition, because once the bone gets inflamed, then, and because of all the tendons getting attached there, it irritates the tendon, and the fascia and the muscles also get involved in that. So basically, in common terms, it's sort of overuse syndrome of the pubic bone, with the main involvement is the bone and the surrounding muscles and fascia.
That's a really helpful way for me to think of it. Actually, it's like, because when you think of shin splints, it's like, okay, most people agree that the tibia, the shin bone, is becoming irritated and painful, and that's the pain. And what you're saying now about this osteitis pubis is it's the pubic bone, which is at the front of the pelvis. That bone is becoming irritated and painful, and it's a problem of too much stress going through the area and not enough ability to adapt to that stress
Recovery,
over a period
like training
of time.
errors, like typical with runners, you get the training errors where, it's too much too soon, you're going for a PB, you want to break your half marathon time, you increase that. And also we know that there are a few things which might be very useful for runners listening to this, especially we see one of the biggest growing population in runner is the 40 plus. So 25 years ago, if you go to the London Marathon and stand there, it usually will be dominated by 25 below young males, fit young men used to do running. But that's not the biggest growing sector is actually the 40 plus. And before it used to be like 80-20, 80% men, 20% women. Now I would say many races, women are more, especially if we go to longer distances. So what we have to understand is the demographics are changing. We're getting, men in there. And if you look at the UK statistics, who is the typical ultramarathon runner? The typical ultramarathon runner is a white male in between 50 to 55 who is well educated. That is the statistics.
Yeah, that's exactly right. Every ultramarathon runner I've met recently has fit that profile.
Yeah, it's a typical who's like, very professionally doing well, 55. Maybe you could say it's like the new middle age crisis sort of thing.
Yeah, it is. They want a new challenge. It's like, yeah, I'll go and run 100 miles. That'll give me something to do.
Yeah, and the key thing is, see, we're so good at trying to stay away with the aging process, we're taking care of diet well, all that stuff. But there are a few things physiologically which changes. One is we know calf muscle strength decreases. We know one of the biggest group which reduces is the calf. And when you lose the calf strength, it puts more strength up the chain. The hips have to work harder. The knees have to work harder. So because you don't have that springiness, and that's more profound in men than in women. That's interesting. Where as you get older, women will smash the men in long distances. If you look at the records, till below 40, men are quite good in that numbers. Once they reach 45, 50, women, tend to beat most men. It's because the biggest reason for that is the decline in the calf strength, which is more profound in men than women. And the second factor is also a lack of hip extension. You lose the hip mobility, and that tends to be more profound. That needs to be more profound in men than women as well. We have to. That's quite interesting.
But yeah, that's true. Like now you say, I can think like because I have like my little screening tests I'll do with runners, and it's always hip extension. It's always guys. It's middle-aged guys or older that have trouble with that. And I can't remember the last time I flagged that as a sort of area of potential concern for a female middle-aged woman. That's
a very common thing. Has been shown by multiple studies. Is with aging, the calf strength gets weaker for men. So we need to always look at the gender differences. We are same, but we're similar, but there are some key profound differences between men and women. Not that it's not about being sexist; it's understanding the physiological differences. We have to adapt with the body, trying to fight our nature. So with men, as you get older, and if you want to be on the top of the game, is making sure that you spend a lot of time on calf strengthening, heavy slow resistance, your soleus, things like that, and also keeping that hip flexibility and that hip control going, because those are the two areas which will naturally decline as you get older. So if you still want to be running in your 60s, 70s, and 80s, those two areas you can't really afford to ignore, especially a male runner.
What would be a good way or good exercise that you would recommend for a male who's looking, so I don't know, some 36-year-old man who doesn't want to lose his hip extension? What might be a good way for me to maintain that?
I want to get the maximum buck with least effort, so I always go for the minimal effective dose. So for me, rather than doing more flexibility, I try to add that with eccentric. For example, like if you want, one of my favorite for hip extension is the Bulgarian split squat. So the studies are very clear. One of the best ways to improve flexibility is eccentric training. We use eccentric training for not just for tendons, but doing slow eccentric strength training has a fantastic effect on improving mobility. So if you want to really get if there's one exercise which is brilliant for improving hip extension, it is the Bulgarian split squat. So, keep the foot on the table or a chair, take some weights, slow, 6 seconds, down, 3 seconds up, and build it up. So one, you're strengthening hips, but also you are lengthening your hips as well. So it's loading with lengthening is the best value for your time, I would say, rather than just trying to physically passively stretch it. So you won't get much out of it.
Yeah, I like that. And that would you then? I mean, the listeners can just Google Bulgarian split squat. It's very easy to find that. It's a common exercise. So, would you have someone do it in a certain way if you're looking to improve hip extension? Is there any
that's
special
a really good point.
consideration?
Yeah. So when I'm focusing more on the hip, I would make sure that when suppose they got a bench or a table, the surface should be higher than their knee. So sometimes the Bulgarian split squat, if it's too low, it doesn't have enough strength on there. There are two important training points if you want to focus on the hips. One is the bench or the table should be higher than their own knee. If it's too low, you won't feel the stretch. That's number one.
Okay.
Number two is you should be away from it so that you feel in the front of the hips. If you're too close to the surface, you don't feel the stretch. So you need to be, taking a few steps away so that you feel from there. So when they're doing it, I'll always ask them, do you feel it in the front of the hips? We're not looking at building the quads necessarily. So it should be away from so that they feel the stretch. And the third thing is making sure that you're focusing more on the eccentric element, So you're taking like 4 to 6 seconds down. And then, so 1:2 generally. So 6 seconds down or 2 to 3 seconds up. So focusing more on the lengthening. So the 3 points would be is good height. Make sure that it's height enough for you, because if you're 5'6", if you're 6'2", it's going to be different. The surface, you can't be using the same bench because everybody's height can be different. Making sure that you're too forward so that you feel the stretch. Number 3 is doing it slowly so that you can do that. Sometimes it might be too much for some runners, especially if they're not used to doing some strength work. So sometimes what I might do in those patients is for 2-3 weeks, I might give them some band, so like CrossFit guys use this sort of called self-mobilization with the hips. So if you go to YouTube, Instagram, you can see thousands of videos for the hip mobility. So they're quite useful for the people who are very stiff in that initial phase, where they feel that restriction. But then eventually I'll progress them to strength-based work.
Okay. And so we're deviating into the exercises here. So I'll just kind of bring us back to, because we got one more suspect, don't we, on our list of
So adductor is basically adductor is a tendon related problem. So obviously when you look into the adductor tendon is so next to the gluteal maximus, the most powerful muscle you have, the inner thigh, is the adductors. So they also go into the pubic bone. Now when I'm explaining this, I've made it to look like actually it's a separate thing, but in reality, when you see osteitis pubis, they seem to come together. So general combination is when you have osteitis pubis, normally you also have adductor tendon involvement. So for therapists, we call it adductor-related groin pain, but for most runners, it's the tendonitis or tendinopathy, what they call it. So you can feel it where the tendon inserts to the bone. And again, this is more common. The adductors generally get problematic when you have change of direction. So generally, if you're doing straight line, you don't really get much of adductors. If you're doing like trail running, for example, then you can feel on the inner thigh. And you can, again, like with the finger test, you can exactly pinpoint where in the groin. It's usually more towards the bone. You can palpate it. And another easy way to check this when I do in the clinic is by a squeeze test. So I'll keep a football or something between the legs and ask them to squeeze hard, and that will reproduce their pain. So with muscles, it's quite simple. Unlike the joint, when you push against resistance, it should reproduce their pain. So if you got listeners here, and if they think it's adductors, they can lie flat, bend their knees, keep a football or a softball, and squeeze it together. And if it causes their pain, it's most likely to be the adductor tendon. In fact, that's one of the exercises we use as well. So it's quite a fairly straightforward diagnosis. So it's basically just like the Achilles tendon, just like the proximal hamstring. It's a tendinopathy, and that's a huge, tendinopathy, as we know, can be quite difficult to get rid of. It's just, chronic and annoying. And generally, I would say 80 to 90% of the cases I see, they coexist. So osteitis pubis, so initially the problem starts as the bone. because of the pain inhibition, the surrounding areas like lower abdomen and the adductors also get involved in that area as well. So it's not unusual that you might have both of these.
Okay. And would you say that adductor tendon pain, or just to clarify for the listener, the adductors are the muscles on the inside of the thigh, right? Then they're near the groin and they attach to the pubic bone and they pull your leg inwards. Would you say that tendon problems in the adductors are less common in distance runners?
100%. So the adductor tendon is, again, going back to the same story, which I'm saying, more common in fast rotational change of direction. The adductors are really like a steering wheel. They really control the pelvis when you're changing direction. But again, what happens is the adductors are overstrained when you have there are usually two main risk factors. Is when you lose that hip mobility, then the strain are more in the joint. When you lose the mobility, that puts a lot of strain on that. And the second thing is the balance between your lower abdomen and your adductors. Suppose you got very weak trunk and core and your adductors are very strong, that creates an imbalance as well. So one of the theories for this is when you have an imbalance between the lower abdomens and the adductors, that could be a problem as well. So, but generally, you're totally right, is you don't really see many adductors. Like, for example, like if you look at runners, we see Achilles, we see GTPS, lateral hip, we see proximal hamstring, but adductor tendon is not so common in runners. So generally, again, if I see that in runners, it's usually because they're losing that mobility, or maybe they're doing trail running, or they had a slip where they're having change of direction. So generally, change of direction is what brings the adductors.
Okay. So then, just from a statistical likelihood point of view, we're thinking potentially this osteitis pubis, this pubic bone pain, which sounds to me like an overload type of problem, is the most likely cause of true local groin pain in distance runners.
Yeah.
And so now, how do we handle that? So we've got a guy, and he's been training for his ultra, for his midlife crisis, and he's had it for 6 months and he's tried to run through it. But now he's got this diagnosis and we're pretty convinced that's what's going on. What does he do? How does he approach this problem?
Yeah. So first thing is, as therapists, we need to be honest with our clients. And I tend to approach it something like a bone stress injury. Like somebody comes with a femoral stress fracture or bone stresses, you're not going to sugarcoat it. You're going to say, this is going to take some time. So the same thing is, this is a condition where, when they hear it, they're a little bit upset because they don't expect to. So normal timelines I say to patients is, unfortunately, you got a condition which is quite hard to shrug off quite quickly, and the average time it takes is between 6 months to 2 years. So I've treated patients even for 3 years. So it's not a condition where if you got a event coming up like half marathon coming in 8 weeks, maybe it's a good idea to cancel that. It's not a condition where I'll make you ready in 6 weeks. So if you're really lucky, if things go well, definitely 5-6 months we can get rid of it. But more likely, you should be honest to that. So it's quite a long timelines on that. And the main reason for that, in my opinion, is many people come too late. They come to me, one, with a lot of pain after 7 or 8 months, and they come to me. So this is a common mistake I see in runners is they get a bit of a problem, they stop running for 3 weeks or 1 month, and they think it'll get better naturally. It doesn't happen with this condition, really. The longer you only get deconditioned. So total rest is not an option for this. So you still have to move on that. So that the timelines is the main thing. Education is really a major problem. So it depends on what stage they come to you. So if they're coming to you limping, struggling, they can't manage your normal walking, they stop running for 3-4 weeks, then the pain management is really important. So sometimes if they're having night pain, I'll ask them to check with the GP, take 1 or 2 weeks of anti-inflammatory to reduce the pain, doing some hydro-based work, getting to the pool, some water-based, aqua aerobics, things like that, just to desensitize the region. One thing anecdotally, and in fact, there's some evidence for adductor pain as well, is compression shorts. It's not going to fix the problem, but it makes you have less pain. It doesn't improve your function. So wearing like this Under Armour, not like any compression socks, which has this X-cross shape, one which has that force on that can give you some symptom relief, and getting them into cross training, like cross trainer or other stuff as well, is really important to minimize the pain. Because if you don't really desensitize the region and reduce the pain, we can't go forward really, because we have to reduce the load. So that when we talk about one thing no one size fits all. But one thing which I'll say to everybody is we have to decrease the loads which go through that area so that it can recover. It means not doing nothing at all, so you still are active, getting other fitness and things like that. So getting the pain under control is massively important. And then this is again a condition where I wouldn't really go on YouTube and try to find my own rehab. This is a condition. There's some conditions you can self-treat. Runners, they don't have to go for every injury to see a therapist. This is where I think you need to see a specialist who can guide you. Is it a mobility issue? Is it weakness of the lower abdomen? Is it you need adductor strengthening? So it has to be personalized based on your findings. What the therapist finds. So generally, it will involve some form of strength training. So it could be initially it might be focusing on the mobility, and some therapists might do some soft tissue work around the tight area just to desensitize, hands-on treatment, dry nailing, and things like that. Which is it's not going to fix the problem, but it can help you to have less pain, which is really important because this pain can be quite adversely affecting their life. So you might use some hands-on treatment there, and then we might slowly build up your exercise. So it has to be having an individualized rehabilitation program. So generally your target would be your lower abdomens, it could be adductors, it could be a trunk, it could be a core, it could be all those things. So where you'll have to, those are the targets where we'll be working on that. And once things are slowly improving, again, one of the things I say to my patient with this condition is your progress will be month by month, not week by week. You're going to have some good weeks. You're not going to have some bad weeks. It doesn't matter. But every month, May will be better than April. June will be better than May. So it will be gradual. And like with any chronic condition, you'll have some flare-ups, some few setbacks, which is normal. And then once you build up the base, then you might think of gradually getting them back into a graded running program like the Couch to 5K and things like that. So it's a very slow recovery process. So I think the mindset, the runner can't be focused on an event. He should be fully committed to the rehabilitation on that as well. So that sort of is your core standard is, education, load management, and a progressive loading strategies, things like that.
Yes, I think the big takeaway there for me is the first thing that we have to do is align ourselves on what is the prognosis here. How long is this going to take? So instead of, like you say, a lot of injuries, either the niggles that you can get over on your own, or they are, maybe at worst a couple of months where you're rehabbing. But now we're trying to switch that and say, okay, if this is what's going on, we're looking at 6-12 months, very, very, very slow. And the priority is calming it down initially.
Yes. Yeah.
You've got to calm it down. And we can't be looking at some external kind of goal, because that's just going to hamper our rehab efforts. So if there's a marathon in the fall and it's spring, it's like, well, you're going to have to evaluate dropping out of that, because you have to commit to doing your rehab properly. And if you've got this other agenda that is going to interfere with you going at the pace your pubic bone is happy with, it's going to sort of pull the rug out from under your progress.
Yeah. So definitely. And the thing is, the more chronic it is, the more longer it's going to take more time. So again, with runners is, you don't have to come to a therapist for every niggles. We understand that, because we don't want to create dependence on therapists where they feel they have to see a therapist for. But generally, a difficult area, I would say 2-3 areas where you would be more wise to seek help early would be, for example, like proximal hamstring is one area, because that can get really problematic if you delay it, in sitting bone. And groin is again a similar area where the longer you're going to not seek help, then if you come quicker, then you might need less sessions and you could be better in 3-4 months. But if you come back with a lot of pain, and and generally for me, it's always best to come before you stop running. So if I see a runner who stopped running for 1 month because of his pain, then you get deconditioned. We know what happens when you stop running. Your muscles get weaker, you lose your cardiovascular fitness. Much, much harder than somebody who has pain, who can still keep running. So generally, by the time you've stopped running and you're so deconditioned, then we have to start from zero again. And that's going to be quite mentally very difficult for many runners, where you become for somebody imagine somebody who's doing ultra marathon and then I have to start him from couch to 5K. It's a bit of an insult sometimes, where you tell them you have to bring him back. But that's partly because of their lack of taking, that help much earlier,
Right.
So again, you don't have to, necessarily seek help. But if you're not, if you're not improving, then coming and seeing quickly will help you to get back quicker. And also we don't have to stop you from running. Suppose you get pain after only 20 to 25 minutes of running. In most of my runners, I'll try to not to stop them from running. For example, you got somebody who got a little bit of pubic pain. He only gets it after 45 minutes of running. So then what I might do here is I might reduce his running from, suppose he's running 5 days, I might reduce to 2 days. And then I'll reduce the distance and absolutely stop all incline, do some cross training. So I'll still try to keep him running as much as possible, so that, because you need the running for the runner's high and for the psychological benefits. But if you're having night pain, if you're limping, you can't even walk for 20 minutes, then unfortunately we might have to stop running for a period. So and that's sometimes unavoidable, isn't it?
So it's the amount of, what you're saying, I think, is that running is okay and is actually beneficial as long as each week or each month the pubic bone is getting calmer, it's getting more comfortable. But if it's staying the same month on month, or it's getting a little worse, what you're doing is too much, and you need to try and figure out, as you just said, a way of just adjusting it down. Maybe not. And I think
totally,
I think what you're saying is that complete rest actually wouldn't use, unless they're limping and really struggling, and then it's kind of
for a
obvious.
week or 10 days or 2 weeks maximum.
Okay.
Total rest is generally, if you're in a very, very bad flare up, you're limping in, you can't walk for more than 15 minutes, and you're waking up at night, then I can see there's benefit of, again, even if you are, there's always something you can do. So even if in that stage, you can still get into the pool, you can still do a bit of walking in the pool and doing some exercise in the pool. So your body is not designed for total rest in any capacities. The common mistake I see in runners is they stop everything, and then wait for magically in 1 month it's going to go away. It's not, because you have to build up the capacity to that area. So unless you got a fracture or something, even in fractures we get them early mobility as well. So there's always a starting point, and this is an interesting study which I saw recently from which published last year, where it showed when runners stop running, they don't do other stuff, they don't keep up the fitness with other stuff. So many runners, it's either running or nothing. So sometimes we have to find a middle ground, and saying is, maybe I can't run as much as I want, but I can still do something else to keep my fitness. Obviously, you're not going to get the same runner's high by doing on a bike, but it's better than just sitting on the couch and feeling sorry for yourself, isn't it? So on that that's important. You have to get the balance for that phase.
But I think what you're saying in terms of the specific strengthening and specific exercises for this condition, I mean, it's a serious injury, and you need an expert really to guide you.
And I wouldn't say
on your own.
It's a serious in life-threatening or anything dangerous like a fracture or anything, but it's a condition which is very hard to shake off. Unless it is quite technical as well, and it might be worthwhile to know, is because by the time they come to me by the second and third opinion, they've done all that. They've gone around the blocks. So sometimes people are stuck there and say, I've seen a physio, I've done all the rehab, things are not improving. Let's imagine you've done 3 months, 4 months, things are not improving. Then you usually you have two options where you're still struggling with pain. One option would be is to go on the injection route, because we're talking about people who have done everything, but they're not progressing. The pain is still stopping them from getting back. And then we always need to have a plan B. As a therapist, I'm not going to stand here and say that exercise, my rehabilitation is going to fix every patient. I need to have the next option where it's those patients I can't help. So one option would be an injection option, where in some people they might need that. Like with the steroid injection, fluorotherapy. So I've got very good sports medicine colleagues where I'll write to them and say, see, I'm not able to progress the gentleman here. He's been doing everything I'm telling him, but the pain is still unbearable and he's struggling. Could you consider some injection therapy? So the sports doctor or orthopedic surgeon will make, or in the NHS, I'll usually refer to them the pain clinic, so they can make the decision what sort of injection and things like that. Again, it's not going to fix it or it's not going to cure it, but it just gives them the less pain, so that they can participate in my. If they can't do the things I am telling them because of pain, then it's pretty pointless, isn't it? So they have to get that moving. So sometimes I'm not one of those saying I'm going to dismiss injection, but it has a role if things are not improving. So that's one option. There's also another option, which is there's only one RCT in this area, which is done by a German group. There's a particular type of thing where I specialize. Is called, many listeners might have know about something called shockwave. So there are two types of shockwave. One is called a radial shockwave, which is for muscles and tendon. There's another type of shockwave called focus shockwave. 99% of clinics in the UK will only have the radial. They won't have the focus. The focus shockwave is for bone healing, so it is less painful and is bigger unit. So there's one RCT, a trial which have shown giving focus shockwave once a week for 3 weeks can really reduce their pain massively and get them back quicker. So that's an option which I have access to that in my clinic. So I will discuss that option. So it's up to the patient to decide. If they're not progressing with my rehabilitation, do you want to go on the injection route, or do you want to go on the focus shockwave route? Which both, in fact, there's more evidence for the focus shockwave than the injection. Definitely, because we know the surgery is it's very experimental at this stage. There's hardly any evidence for. There's some case series like curettage, but generally you don't want to put a plate in that region, go for surgery in that region. Many orthopedic surgeons are not too happy to operate there. So the first option is, I would say 80 to 90% they will respond with that education, load management, loading. If that is not improving, then you have two options. You can go for the injection option, or you can go for the focus shockwave option. But you have to remember, the injection or the focus shockwave is only for the pain. You still have to get back to the exercise.
It's like a means to an end. It's a way to get on to the other stuff that you were just talking about.
You're not going to have an injection and book for the marathon next week. You still have to go back and do the 3 months of or 6 months of rehabilitation. But those two are really good for pain. But then to get you back to that level, you'll have to get back to that sort of area as well. So again, like it's going to be. So most of the time I finished with this sort of get them back. They get good friends because I've seen them for so long. Some of them I've seen them for a year or more. So it's at a slow, but you don't have to see them every week. It's more like, because your body will not change that, but it's having the discussion, setting them a plan. They can, go through that sort of thing. So it's quite a long-term strategy, really.
How long, just one final question, how long would you, in order to say, okay, we're going to have to consider injections or focus shockwave or something else, how long would you give it, presuming that, you are pretty confident that the runner is doing everything you asked and it's just not calming down? Like how long do you give that process before you decide it's not working?
Yeah, if a patient has not seen anyone, for example, they have not had any rehabilitation, then I think it's very reasonable to give them at least 10 to 12 weeks. We can't really, jump into all those options. But if they've already seen other therapists and done all this program, I can't be, we have a saying, like whipping a dead horse. I can't make them to do the same thing again with me for another 3 months. So in that cases, I'll seek an early help straight away. So if you got a runner who has done like 5 months of rehabilitation, seen 2 therapists, still not improving, and they're coming to me because they're not, most of the time they come to me because they're not progressing. So my job is to give them plan B and plan C and tell them, okay, you've done this, maybe, I can send you to this sports doctor for the injection, or I can offer you the focus shockwave, or maybe I think maybe it's not a pubic bone, maybe it's a hip itself. So maybe I need to send you to a hip consultant to do a, particular MRI or a thing to rule out osteoarthritis or a hip impingement. So main thing is getting the diagnosis right and then coming with that planning as well. So so it's a shared decision making, isn't it? Like, I can't be, patients, they can make their own decision. My job is to put the facts in and to give their, options. And some patients will say, no, I can't be bothered. Let me have the injection or let me have the focus shockwave first. And then, they can make that informed decision, especially in a private setting. Whereas in NHS, they'll have to wait for 3 to 6 months for the pain clinic and things like that. So a lot of the decisions are based on the settings and the healthcare systems you work in. What works for UK might not work for the US or from Canada. So again, is working closely with in the States might be much, people might not wait. They might go straight for the injection. I don't know. So you'll have to find based on your local healthcare system what works for you.
Okay, we're going to have to stop there. I know you've been very generous with your time, and I don't.
Yeah, a few minutes is fine. 5-10 minutes if you got, that's fine.
Well, I think we got all the main things, because I think it's very difficult. I mean, if you're going to try and go into how you would rehabilitate this issue, I think it's like you said, it really depends how they present. What's weak, what's strong, what have they specifically been doing wrong that you're going to address. But I think what you've touched on here is really good for any runners with groin pain, because it helps them understand the process by which they would get to the diagnosis. And then they need to work with an appropriately trained professional.
Yeah.
And then they have to understand the duration of time, and you give some good information on, how long have you had it, might be longer. If it's not too long, it should be quicker. I think for the runner, it's really helpful information. I think if we were going to go deeper, it's going to be into what exercises, how do you decide, and all that, which is, it's almost impossible for a runner to really assess themselves and be able to do that.
Yeah. I think the main thing is, just to summarize, is knowing, is it actually from the groin itself, or is it coming from the hip, and is it coming from the back as well? Because sometimes the back issue can radiate into the groin as well. And again, if it's the pubic bone, then having the timelines, if I delay it longer, it's going to take longer to recover. Seeking appropriately trained physio, osteo, chiro, whoever is, because running is just not, there's so many fantastic professionals in different areas. As long as they got expertise in running, and definitely hip and groin, you're in safe hands. And if you've done the rehab, you've done for 3 months, you're stuck, then maybe asking the therapist, what's the plan B? I'm doing everything you're saying. I don't believe just dragging patients for 6 months to 1 year. And then some patients don't, because they don't progress for whatever reason. Then can I go for an injection option? Can I go for focus shockwave? What are the other options available for me? And then getting them back to running. I think main thing you touched here is everything. If you've got an event, you have to that might not be a priority. You have to get rid of this. You have to get back from this injury so that it's not flaring up every time. Because if you've got 4 events lined up, then you can't put your heart and soul into the rehabilitation.
Mm-hmm. Yeah. And you're sort of committing, making that the priority. And I would say as well, it occurred to me as you were talking there, but if a runner is listening to this and really struggling with groin pain, then share this podcast with your physio or your chiropractor. Like, I know as a physio, these are a very difficult injury to treat. And I am always open to, learning more, trying different perspectives, or getting different people involved. So I would say that. And if anybody wanted to learn more from you, is there anything you would point them towards, or anywhere we could sort of follow you online or anything like that that I could put in the show notes?
So I'll send you some links. So I'm active on multiple social media, on Twitter, on Instagram. So I'll share you the links, Function to Fitness, and I've written a lot of blogs on Physiotutors.com on mainly hip pain. So if they're mainly targeted for runners. So if you put Benoy Mathew Physiotutors, you can see that. And for therapists, I've done like a 45 hours, 50 hours program where I go through rehabilitation of running injuries, where I spend a lot of time on hip pain as well. So I can give you a on that. So there's a lot. And if you're in London, and if you want to see me in Central London, so I'm based in near Bond Street. So if you're struggling, as a second opinion, to set a plan as well. So there are different ways of targeting as well. And again, like I would say 80 to 90% of my patients are referred by other physios. So normally what I tend to do is they come to me, I set up a plan. Sometimes I get patients coming from Scotland, even sometimes, before the COVID, I used to get even from international. So I set up the plan, and then I liaise directly with the therapist and say, this is the plan, working together. So it's more like, because I believe it's best that you're treated by a local physio for continuity, but it's more like I can give them like an outline, the do's and don'ts, and give them like a plan, and they feel things are moving on. Sometimes, most of the time, it just confirm what the physio is already telling, but they feel better me repeating that and saying it's going to be the same, isn't it? So it's just good, that expertise. So I work very closely with other therapists on second opinion, and then hand the patient back to them, where they can go locally for their ongoing, because it's going to take a lot of time. So it's best they're seeing the local physio for their rehabilitation and long-term management.
Yeah, and I actually have a question specifically. I'm going to ask you off air in just a second about that one, but I will put links to everything you just mentioned so that people can find you. And you've been on a lot of podcasts, so I'll link some of those as well, because I know that there's a lot to learn there. And I will certainly be interested if you're up for coming on to talk about the hip at some point. So then we could put the hip and groin together. I think that would be a really good sort of comprehensive overview of the problems runners experience in that area. So thank you so much for your time. I'm going to stop the recording there.
Thanks for having me, Mathew.